Right, so we're going to be covering basic joint injections. They're basic procedure plate that you need to prepare, you know, positioning the patient, getting your equipment ready, whatever you're going to be using. Most people don't do it under fluoroscopy or any kind of x-ray, but there are now guidelines that they do it under ultrasound, so you could do that too, but we don't really do it much. But there are people who use fluoro to do some of these joint injections. Some of the joints that you can inject, the TMJ, on the upper body is the shoulder, elbow, wrist, fingers. Basically any little joint space there is in the body can develop pain, can develop osteoarthritic changes, and need for an injection. And in the lower extremities, with the biggest main ones, hip, knee, ankle, foot. So basic on the shoulder, the positioning is the most important. They're showing one way here within the lying position where you have the nice opening under x-ray of the shoulder shown, and your basic key is neutral or external rotated position of the shoulder. They're doing it under fluoro. The anatomy right here, it's do you want me to go up there? You see the anatomy of the shoulder. The key over here is really getting into this space. Think of it as a little cup where it doesn't matter which end you enter from, whether you enter in the anterior lateral, posterior approach, or direct lateral approach to get into this space. As long as you get into the space, the key is you got to avoid ligaments. You don't want to inject into a ligament or on a ligament because you can cause a rupture of a ligament with the steroid. So you get in there. Here they're showing it nicely on fluoro with the indicator on the right side. If it's on you, I usually have my patient sitting, shoulder dangling. I feel the top of the acromion, you feel the space, and I go in the anterior lateral position. But you can always go from the back too, heading the needle toward the acromion. Remember to aspirate so you're not in vessel if you're doing it blindly, okay? I usually do it blindly. It takes me 5 seconds. But in this case, if you have the fluoro, you can then inject dye and see whether it stays within the capsule, within the joint space. And it's most important things you're watching for that you don't have vascular uptake. That's the key if you're doing it on the floor. That's a really nice surround, encapsulating into the capsule and getting the whole space. These are other views, other examples of the injection dye as long as you get into the space. Now there is, the key is once you have put in the injection, change and rotate the shoulder so the liquid inside will start to spread around. If you did it correctly, the patient in pain will have a better range immediately. Will have a decrease of pain almost immediately, like 5-10 minutes. These are another more examples, but the things around the joint, there's Bursal, there's the bicipital groove that you could have the bicipital tendonitis that it could occur, and that's usually you feel the point of pain, and that's in more of an anterior close to the pectoralis muscles, and you feel it and you'll feel the pain, and that's more of a bicipital issue. Then you have, of course, the subscapularis, and you have the subacromial bursa, and by mistake you could also be injecting that when you're doing it blindly. The key is when if you're doing it blindly, you got to go deep, and you're going to be touching os. You're going to feel the os if you go. Of course, if it's a extremely big person, a 1.5-inch needle sometimes might not be enough. But if you touch the head of the humerus or you touch a little bit further, you know you're deep enough, and that's when you inject. When you're not deep enough, you can catch some of those bursa as well. And you could feel easy movement, but it won't be effective. This is now what most people are now starting to do it is the shoulder, the knee, the hips, those joints more under ultrasound. And they find that in ultrasound that they have a better outcome. Because with ultrasound you get to see site of fluid collection. Let's see, post-op procedures. You get fluid, good morning. So they've done under ultrasound, and ultrasound they say that it has a better outcome of a post-injection. That's what's doing now, but it's a technique. You could see the buildup of the fluid. You go in, you aspirate, you put in your fluid, you'll see it going in there. You know exactly where you are. The key with the hip, what they found that people even with hip replacements still continue to have severe hip pain, some patients. And if you do it under flora, you can't see anything but just the mechanical equipment, the bone structures. You don't see soft tissue, you don't see any of the inflammation if there is any, and you really don't inject a person who's had total hip replacement. But however, they found that if you do a hip with a patient's status post a hip replacement under ultrasound, there you could see pockets of maybe even hematoma or maybe a little fluid connection. And by going under ultrasound, you can aspirate those little pockets and relieve the patient's pain. They have done many studies. The key on the hip injection is, of course, placement, and of course, the biggest thing is the landmarks. You don't want to hit artery. You don't want to have vascular uptake. You don't want to hit the femoral nerve or the vein. So palpating, and you should never do a hip blindly. Hips should be always done under some kind of guidance, whether it's ultrasound, whether it's fluoro, because it's a joint that can be missed very easily. And if you have a very big patient, a 1.5-inch needle is not going to make it. You need at least a 3-inch needle and to go in. The key is getting into to be intercapsular. You don't have to be exactly inside the hip joint. You want to be intercapsular. So the exact depth you see here, I usually aim coming from not from the medial aspect, which is where the pointer is standing. I come from the lateral aspect, touch the top of the femur, or slightly like to touch the neck of the femur. Sometimes even slightly below the tip of the femur is okay too. Oh, I'm sorry, the greater trochanter. Basically, for your information, Jeff, you know already. You better know already. Okay. You basically should either be over here, you could be over here, you could be, if you were over here, right? Where is this is the head of the femur, right? This is the cutoff. If you're over here, you are not intercapsular. You're doing a nice deep greater trochanter injection for trochanter bursitis. You need to be, if you see this line right here, you need to be within this space. If you come from the medial approach, you could run into more trouble with the artery, vein, and the femoral nerve. You come from this approach where the patient is lying from the lateral approach, hitting right under the head of the femur. You'll inject your dye, and then you will see the flow staying within the capsule. As long as you're within the intercapsular area, you have the fluid flow. You don't have to be inside the joint itself. Okay? As long as you're within that space of the intercapsular, you get the good flow. And these are all pictures of examples of doing it under fluoro. Now, people can have benefit. The key of doing a hip injection is usually hip pain, and most of the time it's a referral from an orthopedist who is potential of a hip replacement for a patient. And they want a hip injection because they want to know, if they replace this hip, is this patient going to have good pain relief? If with this hip, with this injection done to this hip patient, that's a potential replacement, and they attain a 24-hour good pain relief with increase in functionality without pain, then their outcome of a hip replacement will be very successful. They will get that pain relief. Most of the time, that's the reason why you do a hip injection. Hip injections are not done that often otherwise.
So a few hours, where do you do it that?
24 hours.
So if they have less than 24 hours?
Even if they have one relief,
Right.
1 hour.
Yeah.
But you should technically give them a sheet, and that they come post 1 hour, post 2 hour, up to like a 24 hour, and they bring that to that I had 50% relief. So their expectation of a hip replacement, that's what's going to be. And let's say post 4 hours, they got 50% relief, and that's all they received. Hip replacement will give them that much. So their expectation outcome is going to be that much. They're not going to expect 100%. So they're not going to be disillusioned that they're going to have zero pain. So when they go for it, they might. There's not rocket science that it's going to be outcome, but at least their expectation is that. Again, more addiction. This is under more ultrasound. If you do an ultrasound, it's the best for the hip, really. Before we go on, the basic medications that we use, my preference is Kenalog, triamcinolone, and combination of, this is my preference, bupivacaine or ropivacaine, whatever you have, 0.25% of bupi, 0.2% of ropi, and a 2% lido. Hip, knee, shoulder, they're big joints, about 10 mLs in total. Non-diabetic, no other comorbidities. I usually inject about 2 mLs of Kenalog, which is equal to 80 milligrams of Kenalog, with 4 mLs of 0.25% bupi, with 4 mLs of 2% lido. That's my combination. There are many combinations out there. There are people who prefer Depo. There are people who prefer Celestone. There is no exact thing. I like to combine a short-acting local with a long-acting local. You don't want to do just pure long-acting local because it takes a longer time to immediately have an onset. You want something short-acting that's going to be a quick onset, and then you want something that could last. Some people just do 2% and combine it with a steroid. It's just really preference on what you want to do. The knee, originally they're showing you in a slight flex position, patient laying down. That's how I was taught in the way beginning. With the slight flexure, you feel the medial and lateral components of the knee. You can enter either way. You can enter from the medial superior border of the patella. You can enter from the lateral superior border of the patella. You look for the space, you feel it, and wherever you point it, you access it. This is a nice knee. It's not, doesn't look like it has too much osteoarthritic changes. It looks like the space would be great to enter. So, but you could have a person who has severe osteoarthritic changes, and it's a big obese person as well. You might not be able to find space directly as well as you're finding it there. So it doesn't matter where you find it as long as you find a space. I don't lie them down anymore. I do them in a slight sitting position, slightly reclining. I don't lie them anymore. I used to. This is under the x-ray. You see the patella, you see the opening space. The key is with the knee, if you have them fully extended, you're never going to find it. If you have it fully flexed, you're never really going to find it. You need a slight flexion and the patient to be relaxed, to have that space open so you can go in. Again, as you see on the cartoon character, feeling the patella is the key. And then you go either superior, you can even go inferior to the patella, medial or lateral approach. It's however you can find the space to get into. Each knee is different depending on their anatomical change occurring. So if you feel your knee, you have it nicely flexed. right? Where would you see it, right? This is a good position right there for you. To see this position, if you feel it, it's totally closed on the lateral aspect, but it's open right here. So if you do it under X-ray or fluoro or anything, you could give dye, see the flow, and then you inject. The key is really to end up in the middle, and the PRP is really good too. You could do not only steroid injections, you can do dextrose, you can do PRP injection as well. The key is to be in this space right here, okay? If you're entering from either this point or you're entering from either this point. On X-ray, if you're doing a PRP, the key is to enter and to spread the needle in a fanning position on this side angle. Fortunately, we don't do that many PRPs. Okay, that's all. Another view, the elbow. Now, the elbow, you can have a tennis elbow, you can have a golfer's elbow. So either it's the medial collateral or the lateral collateral epicondylitis. Could happen, and of course you can have also osteoarthritic changes of the elbow joint itself. More commonly, it's more of the tendinitis issues, the epicondylitis, is that what we inject the elbow, not the joint itself, but it's the lateral or the medial components. There are very few cases that you do enter the elbow joint itself. It can be done blindly. It's a very easy space to get into in any person. And you depict to be right in the middle between the humerus and the radial and the ulnar. You see the ulnar cupping, and then you have just go right in there. It's just an easy space to get into. I really rarely do elbow though. Again, the combination of medications. This is a smaller, medium-sized joint. You wouldn't be putting in total of 10. It'd be too much for the space to handle. 5, probably, sometimes 3, depending on the size of the person. A thinner person would be probably 3 mLs, could tolerate it. And you just have to ask the patient, you go slow. If they're having too much pressure, then you don't have to put all the fluid you have in your syringe into the space. If it's a big person, they can tolerate a lot more. So another view. But as I said, with the elbow, the most common injections to the elbow is epicondylitis, whether it's medial or lateral. That's for tennis elbow, golfer's elbow, and that's the code you need. Now for the wrist, again, the wrist injections are very rarely done as well, but we do more for carpal tunnel. That injection is more done. We really don't inject in between the digits either. I mean, you could do maybe a trigger finger, and the trigger finger is not really a joint injection. It's more to the point of where you feel the trigger tenderness and you aspirate and you inject there. Neuroma, ganglion cyst, but interarticular wrist injection is not done as much. If you want to do it, you could do it from the entries from the dorsum of the aspect of the wrist. Don't go through the palmar. Okay, the palmar has a lot more vascularities, and then you would maybe doing more of a carpal tunnel injection if you do the palmar approach, which is the carpal right there. So you would do it from the dorsum aspect, and you should really maybe use a fluoro for that so that you know which joint space you want to be in the wrist itself. It's not a frequently done injection either. Can it be done? Yes. Can you inject anything? Yes. Just avoid ligaments. You don't want to cause a rupture. Again, the volume of fluid is also, you're not going to inject 10 mLs in this space either. You probably anywhere from 3 to 5 or even less. Depends on the size of the person. Again, You know, there's just many pictures on this. Now the ankle. The ankle is done more often than as a joint itself. You could enter it anywhere really, either from the medial, lateral, including the anterior approach as well for the ankle. The key, again, if you're doing it from a posterior approach, you want to make sure you're not touching or injecting the Achilles tendon, because then you can cause the weakening of the tendon and the rupture. And basically, best approach probably is from the anterior lateral type of a placement. And again, this should be done under fluoro, but can be done blindly. If you have an ultrasound approach, ultrasound would be probably the better approach or choice for an ankle, because people do tend to experience a lot of ankle pains, especially if they have a lot of predisposed to ankle sprains, and they have really caused a lot of injuries in their ankle. So this is another area that could be injected. Total volume is really, you have to look at the person. It's an in-between between, you can go up to 10 mLs in this in the ankle joint space. If it's a very small, petite, young person, you're not going to probably do the 10. You're probably going to do less. You could draw for 10 and see how much the space and the person can tolerate. If they're feeling too much pressure, you can stop. My preference is a 22 gauge needle. It's much easier to push through than anything else. This is with fluoro, and they're giving you the contrast so you can see it. The other thing that we inject a lot in the foot is like plantar fasciitis, and they can develop neuromas. You can inject neuromas. So basically neuromas is you feel the most painful nodule. You put directly to that point. You aspirate. Sometimes you can aspirate.
Directly in there?
Right. Directly where you feel the neuroma. This is just a summary of the total stuff, the landmarks, where you need to do, a general overview. Any questions?
How much do you inject into a neuroma? A couple cc's, right?
Yeah, 1 or 2 at the most. You aspirate, see if you can aspirate anything. As well as the trigger finger as well. When you feel the trigger, it could be the middle or this finger, you feel it, you go right to that point.
Okay.
You know, 1 or 2. Make sure you have some steroid in it.
Some pep what?
Steroid in it.
Oh, yeah.